Hi, everybody. I'm Sean Geary. I'm the program director here at Albany Medical Center. I promise I didn't go to Hollywood Upstairs Medical College. I'm originally from just outside of Buffalo, but I've been in the Capital District for more than a decade at this point. I'm a 2014 graduate of the Emergency Medicine Residency program. I went on to complete a surgical critical care fellowship and have been practicing emergency medicine and surgical critical care since 2016. For the last 3 years, I've served as one of the assistant program directors for the emergency medicine residency. I'm thrilled to be stepping into this new leadership role. As an avid skier and hiker, I enjoy everything that Albany has to offer. My wife and I look forward to raising our new daughter Madeline in the capital region, and I hope that you will all enjoy Albany as much as I do. Here at Albany Medical Center, emergency medicine has been a full department since 1985 as part of the first wave of emergency medicine. We've been proudly training EM residents for more than 30 years. What that means to you is that as an established program, we've already fought the big fights. We manage trauma airways. Our residents do procedures on trauma patients. We determine when a patient needs to be admitted to the hospital, and they go upstairs on holding orders. There is no mother may I. Albany Medical Center is Northeastern New York's only academic medical center. The 766-bed main hospital is the tertiary referral center for 25 counties of upstate New York, southwestern Vermont, western Massachusetts, and northwestern Connecticut, encompassing a catchment area of approximately 3 million people. The next nearest tertiary care centers are 2 hours west in Syracuse, 2 hours south in Westchester County, 90 minutes east in Springfield, Mass., and almost 3 hours north in Burlington, Vermont. Albany Med serves as the hub of the region's largest health network, consisting of Columbia Memorial Hospital, Saratoga Hospital, and most recently, Glens Falls Hospital. We are a comprehensive stroke center with an aggressive endovascular team. We're the local STEMI center and the region's only trauma center. We're a level 1 adult and level 2 pediatric trauma center covering 25 counties. Additionally, we have the only dedicated pediatric emergency department and pediatric ICU for the entirety of Northeastern New York. Everyone always wants to know the details. Well, here they are. 89,000 patient visits, including 22,000 pediatric patients, 15,547 transfers accepted to Albany Med, 3,625 trauma admissions, making us the busiest trauma center in the state of New York. 1,463 leveled traumas, including 601 level 1 and 862 level 2s. That's an average of 4 leveled traumas every day, 365 days a year. 130 penetrating traumas in the last 6 months, including 70 stabbings and 60 gunshot wounds. 45 faculty members, a 40% admission rate, 25 counties without another tertiary referral center, 12 residents a year, 2 departments, but only 1 team, a team that we hope will include you. Our faculty group of exceptional physicians consists of more than 45 different full and part-time faculty. And for the most part, our part-time faculty are part-time only in the sense that they work somewhere else within the institution. Our faculty represent a wide variety of academic interests, from research to international medicine and everything in between. Almost half of our faculty group is fellowship trained, with subspecialties including hospital administration, sports medicine, wilderness medicine, EMS, toxicology, medical and surgical critical care, and pediatric emergency medicine. The faculty group is the backbone of any residency, and I'm not bragging when I say ours is truly exceptional. Within the faculty group, there's one group of people you will interact with more than anyone else, and that's the residency leadership team. I'm thrilled to introduce my colleagues, who you will all get to know very well. I'm supported by 3 phenomenal APDs. Dr. Chow is our associate program director, who's also fellowship trained in sports medicine and leads our core content group. Dr. Noonan, our assistant program director, who leads our EKG review course and board review courses. Our newest addition, Dr. Granji, who will be leading our intern case conference series. And the heart of every residency program is the residency coordinator, who keeps everything running smoothly. Carly Banya is our fantastic residency coordinator, you'll all get a chance to meet and interact with during the interview process. Without this dedicated team, nothing that we do here would be possible. Our faculty group is divided into 7 divisions. Our Division of Pre-Hospital and Operational Medicine consists of 4 subspecialty certified EMS physicians, including the 2019 EMS Physician of the Year. Our fellowship has trained several of our residency graduates. EMS is incorporated into our residency through the EMS rotations, event coverage, and an uncommon program where residents provide online medical control for regional paramedics using something that you will come to know as the Remo phone. Our Wilderness Medicine subdivision has hosted 2 successful regional wilderness medicine conferences in upstate New York, and they have designed a very popular MedWar event for our residents, where every year they go into the field to teach, learn, and experience wilderness medicine skills. Our ultrasound division consists of 5 fellowship-trained EM ultrasound physicians and 1 echo-boarded physician. The ultrasound rotation occurs in the first 6 months of intern year in order to maximize the opportunity to use this critical skill set. Our residents have gone on to complete ultrasound fellowships both here at Albany Med and elsewhere across the Northeast. Last year, our residents and attendings completed 5,500 scans as part of direct patient care. That's 5,500 opportunities for ultrasound to have an impact on your patient, where you decide a scan is indicated and execute it. In addition, our residents and fellows scanned over 1,000 people, each for multiple different studies as part of their educational endeavors. Our department has one of the largest divisions of EM critical care in the country. Our group consists of 5 dual-trained EM critical care physicians, 4 EM surgical critical care physicians, including myself, and 1 EM medical critical care physician. We've recently started a program where we take critical care shifts in the emergency department. We provide in situ critical care to our ED patients following their acute resuscitation phase. We have a long history of sending our residents to ICU fellowship with an average of 1 each year for the last 7 years. They've matched locally here at Albany Med, but also at national institutions such as Shock Trauma in Maryland and the Brigham and Women's Hospital in Massachusetts. Our toxicology division consists of 4 board-certified toxicologists. They run our Tox Consult service, and that service answered more than 250 in-house consultations over the last 12 months. In addition, they've taken an active role in managing addiction within our community, supporting over 300 patients through the AMC Suboxone Clinic. Our toxicologists are responsible for the PGY2 rotation, where residents explore toxicology in depth and take toxicology call, gaining exposure to critical care toxicology such as beta blocker, calcium channel blocker, and aspirin overdoses. Our division of pediatric emergency medicine consists of 5 full-time pediatric PEM physicians, including our division chief, Dr. Danziger, 1 EM PEM physician, our chair, Dr. Pauzet, and 1 part-time pediatric PEM physician. Our PEM division has grown rapidly over the last 3 years, not only in terms of personnel, but also our new pediatric emergency department, which will be celebrating its 2-year anniversary this summer. Dr. Chow is a dual-trained emergency medicine, sports medicine physician. She splits her time between the emergency department and the sports med clinic, and we've had several residents go on to sports medicine fellowships, both here at Albany Med and nationally. Emergency physicians are integrated into almost every aspect of the AMC experience. From undergraduate course directors like Dr. Waxman and Dr. Hogan, who is also our immediate past clerkship director, to the postgraduate experience with the assistant and associate deans of GME, Drs. Bartfield and Asher, to hospital administration with the medical director and associate medical directors, Dr. Dan Pauzet and Ashley Taliski, all the way to the C-suite with the brand new CEO of the Albany Med system, Dr. Dennis McKenna. Every one of these physicians still work clinical shifts in the emergency department. In fact, Dr. McKenna recently sent home one of my colleagues on a pre-holiday Friday since, quote, "My meetings got canceled, you should go home." The spread of emergency medicine here is even further when you consider 2 more faculty with EM backgrounds. The director of our Patient Safety and Clinical Competency Center, aka our SIM Center, Dr. McCurlin, is a past chair of the Department of Emergency Medicine. And the dean of the medical college, Dr. Verdile, was an EM physician in Pittsburgh before becoming our dean. Even beyond leadership, I want to tell you a story that happened just this spring. Our EMS director, Dr. Daly, received a call from a local EMS agency about a patient with an arm entrapped in a hay baler. Dr. Daly contacted Dr. Cordy, who oversees EMS response in the counties east of the Hudson. She responded to scene and had the unfortunate duty to perform a field amputation of a hopelessly mangled extremity. The patient was then brought to our emergency department, where they were cared for by our residents and faculty as a trauma activation. And post-operatively, the patient was transferred to the surgical ICU, where her surgical intensivist was none other than Dr. Hanowitz, one of our EM surgical critical care faculty. Here at Albany Med, we can truly say that we will be involved in every level of a patient's care, from the pre-hospital arena, through their ED stay, and on to the ICU. Our adult emergency department consists of a 45-bed main department with a capacity for 16 overflow beds in approximately 21,000 square feet of space. We additionally have a 9-bed super track and a 12-bed observation unit that occupy separate space within the institution. Our main department has 2 primary and 2 secondary trauma bays, 2 dedicated medical resuscitation rooms, in-department radiology including not 1 but 2 CAT scanners, and a dedicated eye space. Our pediatric emergency department covers 35,000 square feet, including 17-bed main pediatric emergency department, a 7-bed pediatric observation unit, and an 8-bed minor care unit. The department will be celebrating its 2-year anniversary this summer, and I can say we've definitely made good use of it. In addition, above our new PEDS-ED is our new administrative space that includes faculty offices and our educational areas. Enough about the location. Let's talk about what it is to be here. Our first-year curriculum starts with a 4-week orientation block. During this block, interns work 10 shifts while learning about the department and how it functions. Interns are double scheduled for shifts for the first several weeks of the month in order to help divide the clinical load and provide you with a built-in buddy. This block also enables us to have residents complete ACLS and PALS as a group, allowing for scheduled recertification at the end of your PGY2 year, so you don't have to go looking for a course on your own time. Beyond the orientation block, our curriculum is focused on those things that we have found have the greatest value in the training of the emergency physician. That's emergency medicine and critical care. Other rotations are targeted with specific goals in mind. Obstetrics is purposefully done during the evening hours at a smaller community hospital with the express goal of getting you the experience of delivering babies without rounding on postpartum. Anesthesia and ultrasound are 2-week rotations focused specifically on skill acquisition. And the orthopedic consult rotation took the place of our old NICU experience after residents provided feedback that they wanted more orthopedic reductions and that the NICU experience was heavily focused on rounding with limited resuscitation experience. The PGY2 year focuses on the care of the trauma patient in the emergency department and continues our critical care focus with rotations in the pediatric intensive care unit and the cardiac ICU. Toxicology caps off the required rotations, and the selective experience is a 2-week block where residents can pursue their own interests. We've had residents complete additional time in various ICUs, spend their time with hospital administration, complete additional time in the community setting, or work with radiology to hone their X-ray interpretation skills. The PGY3 year is our capstone. It consists of 9 blocks of emergency medicine with the same longitudinal pediatric experience as the PGY2 year. The PGY3 year focuses on the departmental awareness and efficiency. Senior residents also get the opportunity to develop leadership and mentorship skills through our Big Red shifts, where you run traumas, aid with resuscitations, and supervise junior residents with their procedures. The PGY3 year also provides exposure to elements of administration and continues EMX exposure with a senior experience. Every resident will complete 1 block at our community affiliate Saratoga Hospital, where they will work alongside our community faculty and gain exposure to the difference in practice patterns between the community and our academic medical center. The elective period is a true wild card. Residents have used this time for fellowship audition rotations or added exposure to things like advanced or pediatric anesthesia. Some have even used this time to travel, with one resident accompanying a faculty member to mainland China and another spending a month working in a district hospital in New Zealand. With enough planning, this is truly a make-your-own-adventure scenario. Let's talk a little bit about the schedule. Our residents work overlapping 9-hour shifts to ensure adequate time for sign-out and wrapping up your patients so that non-clinical time is your own. Our residents come in 30 minutes before sign-out, so the off-going team isn't picking up a complex or critical patient with 10 minutes left in their shift. This buffer allows the off-going team to complete admissions, needed procedures, or wrap up documentation without having to worry about seeing new patients. Reflecting increasing clinical responsibilities, shift counts drop over the course of 3 years from a maximum of 20 for PGY1s to 18 for PGY3s. There are 4 weeks of vacation and reading time built into the EM blocks for each of your 3 years. Let's talk about didactics. The base of our educational curriculum is our 5-hour protected didactic time on Wednesday mornings. Wednesday mornings, the department is covered with a combination of APP and additional attending providers so that residents can have uninterrupted educational time. We've tried to minimize death by PowerPoint and utilize a combination of small group didactics and hands-on practical learning to convey the core curriculum. Over the past 4 years, we've transitioned the core curriculum to utilize the Foundation series for the PGY1 and 2 classes and our own homemade cases for the PGY3s. We incorporate a variety of attending-led lectures, resident-led lectures such as intern case conference, trauma conference, and senior talks, resident-led whole group discussions such as morbidity and mortality conference, and hands-on learning through our recently overhauled cadaver lab experience. The schedule is real. This represents the July educational schedule from 2020. And as you can see, it includes things like trauma conference, orthopedics, board prep. Our residency also was an early adopter of simulation, and as such, we've had a while to continually enhance our simulation experience. The Patient Safety and Simulation Center is state-of-the-art. Our residents go to the sim lab 4 times a year and work in teams of 3. There's 1 resident from each PGY year, and they each run a case targeted to their level of training. We do this so that sim remains challenging without being intimidating. In addition, we utilize simulation as part of an interdepartmental team building experience to orient both our new residents and the new surgical residents to their trauma roles every spring. Wellness at Albany Med takes many forms. We start with our homegrown wellness program. Each resident is assigned a 3-person family with 1 person from each class, and this provides a built-in support system from day 1. Each family is expected to touch base with each other once a month, and once a year, each family is responsible for running a social event for the entire residency. 3 families are combined into a house, and each house has a faculty leader. The houses will be competing for this year for the first time in something we are calling the House Cup. Here at Albany Med, we recognize the importance of wellness and have endeavored to incorporate this philosophy into elements of our residency program, from the schedule to the educational curriculum. Our overlapping shifts are designed to make sure that your non-clinical time is your own. Our monthly steering meetings are used to address concerns of the residents and work towards reasonable solutions. The Hospital Fitness Center is state-of-the-art and available to residents at nominal cost. Journal Club is as much a social affair as it is an academic endeavor, and our residency Med War is an annual favorite. Beyond the classroom, we have several annual events, including a resident ski day and the annual resident wellness day, which for the last several years has taken the form of resident versus attending paintball. We also provide departmental funding for whole class conference attendance. Typically, the PGY2 class starts their year with a trip to New York ASEP, and the PGY3 class all go to national. Beyond formal events, the frequent night shift brunches or post-evening trips out reinforce the social network that is the resident and faculty group. Why Albany Med? I've spent a lot of time pondering this question recently and asking all of my residents and colleagues. In many ways, each answer is unique. I wanted a place with lots of trauma. I wanted a place with integrated pediatrics. I wanted a place where I can teach. I wanted a place where emergency medicine is leading the institution. I wanted a place that was close to the mountains, but still felt urban. The answers I got were as varied as the people I asked. The one thing that they all had in common was the people. I came here not knowing that people could be this nice to each other. I stay because my colleagues are my friends and family. I'm a lifer. I came back because it feels like home. In almost every answer, there was a theme that I struggled to convey through digital media. This place is addicting, and the people make it work. Thank you for taking the time to listen to me. If you have any questions, please don't hesitate to reach out. We would be happy to hear from you. And I look forward to reading your applications in the fall. Thank you again.